partner with Foley and Lardner's healthcare practice, and I would like to welcome you to the third installment in our Bundled Payment Best Practices webinar series. Today's topic is how to make CJR a success, implementing a winning strategy. The Comprehensive Care for Joint Replacement Program is the first mandatory alternative payment program that's been introduced by CMS. In the second year, starting January 1, 2017, approximately 800 hospitals in 67 MSAs will be required to take downside risk with respect to the covered procedures. Developing a strategy for success in the CJR program will take some thought and time to both develop a strategy and to identify and contract with partners who will share that risk with the responsible hospital. Hospitals should now be putting together a strategy and trying to identify those with whom it's going to offer contracts. Today we hope to address issues and talk through a variety of things that we believe will be of assistance to hospitals as they move forward into the CJR program. And we have a great panel today to assist us. My partner, Chris Donovan, also a partner with Foley and Lardner in the healthcare practice, focuses his practice on advising companies and their investors and lenders in mergers and acquisitions, recapitalizations, buyouts, and restructuring, as well as advising on a broad range of commercial arrangements. Chris has particular experience in the health service, particularly post-acute and life sciences sectors. We're also pleased to welcome today to our panel Duncan Simpson, a Vice President at Remedy Partners. Duncan leads the orthopedic vertical and works with independent physician practices and hospital partners to successfully operationalize orthopedic bundled payment programs. Before we start with the formal program, I'd like to address a couple housekeeping matters. Today's program will run for 60 minutes. We will apply for one general CLE credit for today's program. For those of you interested in CLE, please listen carefully for the code that will be announced during today's broadcast. Once you hear the code, please enter it in the pop-up box that will appear on your screen. All New York, New Jersey, and Kansas attendees applying for CLE credit must also fill out an attorney affirmation form, which can be found in the resource list widget. Electronic questions can be submitted through the broadcast by clicking on the Q&A tab at the bottom of your screen. We will do our best to answer the questions at the end of the broadcast, and if we don't get to them, we will respond to you after the presentation. Copies of the slides can be obtained in the resource widget as well. At this point, we'll just move on with the program, and I'll turn it over to Chris Donovan. Chris?
Thank you, Fred. Appreciate it, and welcome everybody to the webcast. We've got sort of a three-part program for you today. One, we're going to do a little bit of an overview of the CJR program, just to kind of refresh for everybody and focus a little bit upon the basics of the program in terms of the gain share and the stop loss requirements or stipulations. We're going to talk a little bit about some of the program waivers, the contents of some of the gain sharing and collaboration agreements, and finally I'm going to talk a little bit about the fraud and abuse waivers. Duncan is going to follow me up with some more business analytical strategic advice. We're going to have some Q&A amongst ourselves, and then we're going to open it up for Q&A with the audience. And there's a spot in your computer where you can ask Q&A on the bottom of your screen. It should say Q&A, so we're happy to take questions there. I think when you're done with this, you're going to see that really, for the purposes of this is truly a multidisciplinary kind of set of issues to deal with. There's certainly legal issues, but there's also strategic and analytic and data issues that I think are going to be part of a lot of the input and decision-making hospitals and physicians and post-acute providers who will have to collaborate on this are going to have to come together on to really make this a success. So with that ado, I'm going to sort of get into the slides, and I'm starting with the general overview now on the comprehensive care for joint replacement slide. And as Fred indicated, there's this is really a system where acute care hospitals are going to be really the entity that's unlike the bundle payment care initiative where parties are going to be convening together and sharing risk sort of jointly. The hospital is sort of the hub and spokes on this model. The hospital is the one that is ultimately going to bear the risk or the upside from exceeding target payments, and it's going to be up to the hospital to decide when and how much and with whom to share that upside or downside. So this is a mandatory program, unlike the BPCI, and as Fred said, it's the first mandatory one from CMS, probably the first of many to come based upon MACRA and some of the other changes that are coming, and certainly the public announcements from CMS about the high percentage of total fee-for-service revenue they hope to attribute to bundle payments over the next 2 years. So although there was some adjustments initially over that, we're talking 67 MSAs and roughly 800 hospitals, so really a high number. The program formally began on April 1st, 2016, and as Fred mentioned, in the first year there's no downside risk in the program. We were just talking before the second year of the program begins January 1st, 2017. So actually that runway that I think a lot of people may be relying upon is sort of an opportunity to kind of get their act together and to do some planning is not going to be a full 12-month runway, and it's probably, given the complexities of discussing how to allocate risks and so forth and potential investments, now is probably the time to plan this and put a strategy together if you're subject to it. So it is a 5-year program, and as I said, that first year is going to be sort of like a short stub year. Moving on to the next slide. Reconciliation payment model, and just some terms of art. Reconciliation payments are payments from CMS, and alignment payments are payments to CMS. That's sort of the lingo that the regulations use. But basically, this is a retrospective two-sided risk model with the hospitals bearing the financial responsibility for the care. The providers and suppliers, much like the BPCI, they continue to, bill in accordance with straight Medicare FFS. And at the end of a performance year, there's a comparison of the actual episode spending with a target episode spending. I'm going to talk about that in a second, about how that's calculated. So this particular program has sort of a collar on the upside that can be gained, as well as a stop-loss downside on the amount of loss that can be incurred by a hospital. And in the slide here, you'll see that there's, roughly, some symmetry to the two, with the exception of, sort of in year 1 and 2. But in years 1 and 2, the gains are limited to 5%. The losses, there aren't any in the first year, as a way to sort of get people familiar with the program. You go to year 3, you're capped at 10%. Year 4 and 5, it goes up to 20% in terms of gains. On the downside, year 2 is at 5%. Year 3 then is at 10. It's a little more generous than the upside version of it. And then years 4 and 5, it's also at 20. So that's, there was some discussion of that in the regulations as to how that worked out, but that's basically the collar within which, the program operates. There's some carve-outs and protections for rural, sole community, Medicare-dependent, and rural referral centers, hospitals, with stop-loss of 3% for year 2 and 5% for years 3 and 5. The other thing I want to mention here before I flip is that there's some quality measures that really revolve around complication rates and patient satisfaction scores that are calculated as part of this, and those scores are a gating feature to achieving any kind of reconciliation payment from CMS. In other words, you have to hit the benchmark for those quality metrics on a national basis. If you don't get any upside. If you exceed them, it can actually serve to reduce the discount that I'll refer to in the next slide, the 3% discount for which savings get made by 1 to 1.5%. So there's sort of a quality overlay as well on these caps and collars that feature into this that can kind of move the needle. In one sense, act as a gate, and in another sense, act as an incentive to further improve quality. Moving on to the next slide, target prices, which I just mentioned. Each hospital will have its own target prices set by CMS based on 3 years of historical data. And it's against that benchmark that the hospital will calculate the reconciliation or alignment payment for that particular hospital. In order to access the savings, you actually have to achieve savings by an amount in excess of 3%. There's sort of a 3% deductible featured in. And as I mentioned before, that deductible can be reduced if you achieve above benchmark in terms of patient complications and patient satisfaction scores in accordance with some of the benchmark standards that are laid out in the regulations. So it's similar in the sense to the MSSP program. In that sense, you have sort of this discount that somewhat floats, and you need to sort of punch through that before you hit savings. The target rate is a blend of, this is really probably one of the more important things, and I think one of the more strategic starting points for most hospitals is where will their target date be against which they're going to be judged. And it starts with this 3 years of historical data, but it actually floats over the 5-year period of the program. It sort of starts with hospital-specific data, and over time it pivots to purely regional episodic data, such by the 4th year you're 100% on a regional benchmark. So to be more specific, in years 1 and 2 of the program, 2/3 of that benchmark is based upon the hospital's historic 3-year pricing, and 1/3 is based upon 3 years of regional pricing. When you get to year 3, the ratio flips so that the target price is only 1/3 of the hospital's historic pricing and 2/3 regional pricing. By the time you get to years 4 and 5, it's 100% regional pricing. So, I think, and actually for those hospitals that I think have less than 20 episodes of CJR over a 3-year period, it's 100% regional from the get-go. So I think, and Duncan can talk about this, finding out where you are on that spectrum during this first year, this sort of grace period first year, I think is really going to be critical to determine for most hospitals, what their strategy is going to be, how aggressive they need to be, depending on how far, for example, they are from regional pricing, how far over it or how far under it. Moving to the next slide, there's 2 types of waivers here. There are fraud and abuse waivers, and there are programmatic waivers. And there's really 3 programmatic waivers that are dovetailed into the regulations here. One is there is a waiver of the 3-day rule for SNF coverage that an individual has to have a 3-day inpatient hospital stay in order to be eligible for SNF Medicare reimbursement following the anchor hospitalization. So beginning in year 2, since year 1 there's no downside, there is a programmatic waiver that you can transfer a CJR patient to a SNF short of a 3-day hospital stay and still allow the nursing home to bill Medicare, again, subject to the CJR reconciliation process. So that's a big one. There's some conditions associated with it. There's a requirement that SNFs have to be rated at least 3 stars or higher for 7 of the last 12 months on the CMS Nursing Home Compare website. And you'll see later on when I talk a little bit about the collaboration agreements, that's going to dovetail into the selection criteria, obviously, that hospitals use in terms of deciding who their collaboration partners are going to be for this program. And then there are some patient protections and beneficiary protection provisions associated with this. Beneficiaries must not be discharged prematurely to SNFs, and they have to be provided with freedom of choice. I'll talk about it in a minute, but patients have to be notified that they are in the CJR program, that post-acute providers, for example, are collaborators with the hospital, and consistent with the ACO regulations. There is freedom of choice here with the patient. The one thing that's different here, that's a little bit different than ACOs, though, is that there is language in the regulations that allow hospitals to clearly designate, consistent with patient choice, that post-acute care collaborators who they are in contact with are preferred providers of theirs. So I'll get into that in a second, but that's a significant deviation from the MSSP regs, which don't have that language in them. And I know hospitals and PAC providers have been looking for that, and it did appear in the regulations. The second programmatic waiver that's of significance relates to home visits. For CJR post-discharge home visits, CMS is waiving the incident to direct supervision rule for physician services. So this allows clinical staff of a physician or non-physician practitioner, nurse assistant, nurse practitioner to furnish a visit in a beneficiary's home just under the general supervision of a physician. It's permitted only for beneficiaries who do not qualify for Medicare home health coverage. So, for example, they're not otherwise homebound. And there's a maximum of 9 visits during the episode billed under the physician fee schedule using HCPCS code created specifically for the model that is allowed under this particular waiver. And I think you'll hear from Duncan that I think one of the key data points with respect to CJR is the ability to discharge people in an appropriate clinical fashion directly to home, as opposed to, for example, another post-discharge location in terms of value. And I think these kinds of visits and this type of waiver obviously was designed to encourage that kind of discharge. The third type of waiver under the CJR is for telehealth. The CJR model waives the geographic site requirement for any service on the Medicare-approved telehealth list, as well as the originating site requirement to permit visits to originate in the beneficiary's home or place of residence. These aren't a substitute for home health visits paid under the home health benefit. And there's a requirement that all telehealth services be furnished in accordance with all other Medicare coverages of payment criteria, except that the payment for the special home health visits under the model will be paid at a special rate. So this again, I think if you read these 3 waivers together, the SNF 3-day rule, the incident rule for home-based visits, and the telehealth visits, I think these are designed to make a discharge to a non-institutional setting under appropriate circumstances and supervision more achievable to provide the same or better results at lower cost. Moving on, I'm going to talk. I talked before about gain sharing and collaboration agreements and distribution agreements. What the CJR does is it allows hospitals to enter into contracts with physician groups and post-acute providers. Recall that the CJR payment covers every inpatient and outpatient service from the date of admission into the hospital to a point 90 days post-discharge. So this is covering all Part A and B services for that entire spectrum of care. And the idea is that hospitals went into collaboration agreements with post-acute providers, or what's called distribution agreements with PGPs. That's the terminology they use. But what it does is it establishes certain floors and caps to the amounts of risk that hospitals can move onto various providers, and amounts of risk and upside and downside that the hospital has to retain. So specifically, hospitals, no matter what type of gain sharing with PGPs or PAC providers they enter into, they have to retain at least 50% of the downside risk associated with any payment to CMS. So if there's a alignment payment to CMS, 50% of that alignment payment has to come from the hospital, and the remaining 50% can come from non-hospital partners. However, of that remaining 50%, only 25% can be attributed to a single collaborator outside of the hospital. So I think when you sort of look at this, there's some pretty wide runways in terms of how a hospital doesn't have to decide to share any upside or downside, can retain all of it, or if it decides to move risk around, it can move up to 50% of that risk around. It doesn't have to do it in pro rata fashion. It can do it in different percentages, but it can't heap all of the other 50% down onto one collaborator and leave another party with no risk unless it picks up that piece. So there's the bottom line is there's flexibility on how the risk sharing can occur, and CMS designed this so the hospital still has to retain 50% and can't allocate more than 25 to any single collaborator. The contracts cannot be based on volume or value. They have to be tied to certain quality metrics that have to be agreed to up front, which I'm going to talk about in a second. And the other way that gain sharing can occur if there are actual tangible internal cost savings associated with a redesign of a plan of care that the hospital can quantify and verify. Those savings as well can be distributed to the collaborator involved in providing that care design. So that's a summary of floors and caps. Now, the other thing associated with these agreements, the hospitals have to enter into written agreements with collaborators. It says PAC requirements here, but it should also say PGP requirements. They have to be written agreements documenting the gain sharing agreement, and hospitals have to develop a written set of policies for selecting providers and suppliers. The criteria must be based on quality and not on volume or value. PGPs can contribute to care redesign. And I think centrally to this whole process of selecting providers, executing collaboration agreements, gain sharing agreements, and the metrics for sharing have to be dovetailed into the providers, into the hospital's compliance plan. So this is something that's really going to have to be dealt with at the board level and sort of baked into the compliance process of all hospitals. We were talking a little bit earlier about the MSSP program for waivers, and under the MSSP program, as people probably know, there's some pretty detailed requirements to adopt fraud and abuse waivers, one of which is you actually have to have a written board resolution, which is pretty detailed. Technically, the fraud and abuse waivers in the CJR program are self-operating, but when you really look through it, since the board has to adopt quality criteria for selecting providers and have to tie those to its compliance plan, it's not, we believe, totally accurate that these are self-operative, but different from the ACO MSSP waivers, for example. They don't have to be posted, for example, on the hospital's website. So that's a brief discussion of the written agreement that is required associated with these. I've got 2 or 3 slides here that are going to briefly discuss the fraud and abuse waivers, and then I'm going to hand it off to Duncan. There's really 3 waivers here. One is a waiver for distribution of gain sharing payments and alignment payments under sharing arrangements. These gain sharing arrangements or collaboration agreements would primarily be with post-acute providers. I'll talk about those in a second. The second is really, and these are waivers from the Stark Indiana kickback statute and the civil money penalties law. The second is really a similar and sort of correlative type of waiver for physician group practices and practice collaboration agreements. And the third is there is a waiver for patient engagement incentives provided by the hospital. The hospital has to provide them to Medicare beneficiaries in CJR episodes. I'm not going to talk a lot about that, but basically these are non-cash physical items that, for example, promote drug adherence or monitoring of post-discharge condition that they're to be provided only by the hospital. So there's examples in the regulations of the type of, for example, technology and monitors that hospitals can provide up to a certain dollar amount, provided the equipment is returned, that are waived under these fraud and abuse waivers. The gain sharing and alignment payment waiver has, generally speaking, 6 requirements, and they're set out in pretty good detail in the regulations. There has to be a written agreement. The hospital has to update its compliance plan, reflect the sharing arrangement, and the hospital has to have policies and procedures in place as to how it's selecting providers and suppliers as CJR collaborators. There's requirements on beneficiary choice and beneficiary notice, meaning if a patient is admitted to the hospital as part of a CJR program procedure, the patient has to be notified of the CJR program, of the participants in it, and that the beneficiary, notwithstanding the hospital has collaboration partners, still has beneficiary choice associated with getting their care. And in order to achieve the waiver, the hospital cannot add additional conditions or limitations or restrictions other than those permitted by the CJR rule. So anything obviously related to volume or value or loan transactions or other non-CJR features can potentially jeopardize the waiver. And as I said before, to perfect the waiver, the criteria for selecting the provider or supplier as a CJR collaborator must include criteria related to quality to be delivered during the episode. And those criteria have to be reflected in the collaboration agreement. The collaboration agreement, to qualify for gain sharing, the collaborator has to achieve those criteria. They have to be related to the episode of care, and they have to be reflected in the gain sharing arrangement. So I think with that, I am going to now, and there'll be plenty of opportunity, as I said, for Q&A, turn it over to you, Duncan, and you can give us an overview of Remedy Partners, their services, and how your skill set plays into this area and some of the observations you guys have.
Great. Thanks so much, and thanks everyone for joining us this afternoon. Once again, my name is Duncan Simpson. I'm a vice president here at Remedy Partners. I lead our orthopedics vertical, so working very closely with not only physician group practices, but hospitals in CJR and the BPCI program across the country. And just a quick background on Remedy. We're the leading industry experts on these emerging value-based Medicare reimbursement models. Remedy is the largest nationwide bundled payments company working with hospitals and other healthcare providers to manage the care of nearly half of the patients in the CMS Bundled Payment for Care Improvement, also known as BPCI, which is the predecessor program to CJR. And under the BPCI program, which was launched by CMS in 2013, Remedy is working with over 900 healthcare facilities to help manage the reimbursement risk and care for over 200,000 Medicare beneficiaries annually. We provide an end-to-end solution to our partners to enable them to identify covered beneficiaries, coordinate their care in the acute and the post-acute setting, and optimize the reimbursement from CMS. And just before we discuss some of the insights we've gleaned from the BPCI program, I just want to provide a quick reminder on some of the things that we have found to be successful in the program. One of the things is that bundled payment programs can be challenging, obviously. There's several things that need to happen simultaneously for a successful program. One is really understanding the target price, the underlying data, and ultimately the levers to come in under that target price, including internal cost savings. A couple other ones are identifying patients that are eligible for these bundle payment programs, and then creating alignment amongst providers and financially incentivize them if appropriate and compliant. Ultimately, what you're trying to do is put the patient at the center of care and ensure a high-quality outcome for that patient, for that beneficiary. So if we take a look at this first slide, although the average major joint replacement in Medicare fee-for-service costs approximately $27,000, there's incredible variation depending on where the patient is discharged to right after their anchor inpatient stay. So if you look at the chart on the left and you kind of work your way from the right to the left, which is a little bit counterintuitive, but you'll see that the largest bar item is the LTCH, which is long-term care hospital. And on average, if a patient, after undergoing a major joint replacement, is discharged to a long-term care hospital, that average episode cost for the total episode will be about $74,000. And if you continue to move to the left, if they're discharged to an inpatient rehab facility, the average episode cost is $41,000. And then it's $36,000 for a skilled nursing facility, which is 30% more than the average overall cost for a lower major joint case. And then, again, if you look at home health, if a patient is discharged to home with home health services, it averages $20,000. And then if a patient goes directly home with limited services, say outpatient PT, that average case cost is $17,000. So meanwhile, if you look at the pie chart on the right-hand side, you can see that discharge across the board, discharges to SNF are about 40% of the overall volume. So something interesting to note. And really, as you break this down a little bit further, 44% of the costs are typically attributable to the anchor inpatient stay, and 33% are related to the post-acute. But 75% of the variability in a total episode cost is driven by that post-acute space. So obviously that gives us one of the levers to focus on in this program. So really, success in CJR begins with understanding claims data. CMS provides raw claims data, which requires the user or the hospital to stitch together these claims into episodes and costs with all the rules of the program, exclusionary criteria, and really understanding the underlying claims data itself into a longitudinal view on the patient. So really, it's critically important to have a good analysis of the claims data, but actionable data is key. And so if you look at the left-hand side, this is an example data, shows the first site of discharge percentages for lower major joint for one of our partners. You can see that close to 80% of lower major joint cases were going to skilled nursing facilities. So discharge to SNF, the highlight is a little bit off, but if you look at discharge to SNF, it shows a 78.1%, so about 80%, way above the national and the regional average. And then episodes with a readmission were also higher than average, at about 12.8%. And keep in mind, one of the things with the readmission rates in this program is that it's all-cause readmissions for a 90-day period. So oftentimes we present data to partners and they're saying, no, my readmission rates are much lower than that. And so the thing to keep in mind there, it's 90 days as opposed to a 30-day look. So if you look at the right-hand side of this slide, you can see that the contribution of sending 80% of patients to skilled nursing facility, it costs on average $9,650 an episode, which is 3/4 of the cost of the anchor inpatient stay itself at $12,726. And then the same is if you look at the readmission cost, as identified as post-anchor inpatient and post-anchor Part B, it's $3,871. So these are things to really hone in on and focus as you look at these types of bundled payment programs. Where are the costs? What do we have to address? And what can we do around that? So now that we've identified two areas for improvement or focus, let's take a look at the differences between two surgeons conducting hip replacement, knee replacement, so lower major joint at the same facility. So if you drill down and you look at Surgeon A on the left-hand side, he or she discharges over half of his patients to a skilled nursing facility and almost a quarter to an inpatient rehab facility. And then if you look to the right, and even though these two surgeons have very similar volume, if not the same, Surgeon B is sending 2/3 of his patients home and only 1/3 to skilled nursing facilities with no inpatient rehab facility usage. Meanwhile, Surgeon B had 0 readmissions in this quarter. It's unusual, but it's true, and you often find as you dig into the data these types of discrepancies or variability in care. So really the point of all this is that the data will inform care redesign efforts and focus in the CJR program. So next, let's take a look at what happens after the patient leaves the hospital. And before I do that, I think a little bit of a primer on reimbursement for skilled nursing facilities. So if you look at this is RUG rates in Miami-Dade County, and RUG is the Resource Utilization Group, or how skilled nursing facilities are reimbursed per day for their services. And it's really based on intensity of service. So if you look at the individual rates, which are RUX, RHX, RLX, and these are essentially showing the cost per day for rehab services plus extensive services, and then for just rehab. And the message here is, if you look at, first of all, RUX stands for ultra high, and RHX is very high and low. So it's a low rehab services to high rehab services. But if you look at the bar chart on the right, the orange in the bar graph represents the proportion of very high and ultra high services. And as you can see over time, if you think of the macro situation in the SNF reimbursement world, it has been going down since 2000. But what you see is that there's been a corresponding intensity of services conducted. So that orange bar chart has grown over time. So what that means in translation is that skilled nursing facilities are providing more intensive services to capture more reimbursement. So as we get into the post-acute variation, there's tremendous variation amongst providers in the post-acute space, particularly among, skilled nursing facilities or facilities themselves. And finding and working with the best performers is critical for this program. And this is a risk-adjusted chart, so patients have been risk-adjusted, so it's more of an apples-to-apples comparison. But if you look at the top quartile of SNFs, and this is for Seattle, Washington, if you look at the top quartile of SNFs in Seattle, they're almost half as expensive and have half the readmissions as the bottom quartile. And that's critical. And really, not only do we see this from a quantitative perspective, but once we actually have conversations with these skilled nursing facilities and work with our hospital partners and other providers, qualitatively we get that feedback too, that there really is a tremendous difference in care being provided. So those are some of the things to focus on. And another is really, how do you wrap around care redesign in this new environment? And so we have a pretty standard model that we like to apply, and it's variable depending on the local situation. Every hospital is different, every provider is different, and what we try and do is provide a framework or an outline of how care redesign could go, but then tweak as necessary to the local situation. But really, with lower major joint, most of these, about 85%, are elective hip and knee cases. And so you have a tremendously unique opportunity in this bundle payment program, in CJR and in BPCI, to assist the patient and essentially set the framework in the preoperative period. So framing the patient's recovery in the preoperative period with their surgeon, setting them up appropriately with some preoperative physical therapy, and then following up with them in their H&P, and then otherwise either through a call or through an in-person visit to their home to assess their home situation and to essentially prepare them for an appropriate discharge. And then in the acute care setting, there's a number of things that can happen around case management, around the way that the physicians are interacting with the patient, the timeliness of rehab or PT in the hospital, and then once the patient is discharged. So following up in that 90-day period is critical. So tracking and understanding where that patient is in their recovery, whether they've gone home with limited services, who's following up with them to ensure that they're progressing as expected. And if they aren't progressing, what is the escalation process around there? And it's the same thing as if a patient goes to a home health agency or a skilled nursing facility. But what we try and do is, around these programs, we try and wrap a performance network of high-performing skilled nursing facilities, those in the top quartile, and the same thing with home health agencies. So really working with the best ones as identified through qualitative and qualitative means. I just want to share a little bit of our experience. We, as I had mentioned before, we're in over 900 facilities across the United States, but right out of the gates, we work with our partners very closely to set them up successfully. So as soon as they're at risk, that they understand what the levers are for a successful program, and that they're operationalizing the things that need to change to have a successful financial outcome of the program. And really, right out of the gates, this is actually an example of some first quarter performance. Increasing the discharges home, decreasing the discharges to skilled nursing facilities and inpatient rehab facilities. And as I showed before, that translates directly to dollars and financial performance. across the board, we have been generating positive gross savings for our partners. In fact, several of our programs are generating double-digit savings and would be bumping up against the stop gain or cap in the CJR program. All the time, focused on those outcomes and metrics. So we have reported 90% patient satisfaction, that they really feel as if better care is being delivered. So again, putting the patient at the center of this. So very quickly, I just wanted to reiterate some of the things that Remedy offers to be successful in these bundled payment programs. First and foremost, data analytics. Managing and stitching together the claims into some actionable insights is really the first thing. We also provide on the reconciliation front. We have gone through a number of these reconciliations. We know where to look for errors or issues with the reconciliations and the claims, and we've worked through thousands of those now. And the other thing that we look at as a critical component is some sort of operating system for these bundled payment programs. And we have a proprietary suite of software or a software platform that really tracks and manages these patients from the preoperative period to post 90 days discharge, and allows for people to input clinical information. It can be automatically hooked up through an HL7 or ADT feed to the hospital's EMR, the physician's office EMR, and then also in the post-acute space, we have connections there. So there's clinical information being uploaded to it. But what it does at a high level is, because keep in mind the claims delivery from CMS is about 9 months delayed on average. So you're not getting real-time reporting from CMS in the claims. It's a look-back period. So what Episode Connect does is that it aggregates the information and is able to provide you real-time reporting, so you're able to make those adjustments, those care redesign adjustments on the fly as necessary. And then finally, an important consideration is, once the patient is discharged to either home or outside the hospital, what's the process for follow-up? Again, to identify if the patient is progressing as expected, or if not, what is the escalation process, so they're not just showing up in your ER or another hospital's emergency room and being readmitted, and so being dinged or penalized for that. And that's the end of my portion of the presentation. We'll open it up for some Q&A.
Terrific. Thanks so much, Duncan. Before we get into a little bit of a roundtable here, I thought I'd announce the CLE code. It is, and please write this down if you're applying for CLE, AY0, OBI. AYOBI. And now I thought we'd have prepared some questions that we thought would elicit some of the interesting kind of feedback, and we'll just go around the horn on it, and then we'll try and get to see some of your Q&A as well. There have been a couple questions that have been asked. I'll address the first one to Chris. Chris, what metrics should systems use to measure performance by collaborators? Should they just be efficiency-based, sort of length of stay, spend per beneficiary, quality-based, complications, patient experience, or some combination?
Yeah, Fred, I think in all likelihood it's probably going to be a combination for a couple of reasons. Number one, I think, under the regulations, as much as the focus, I think, may initially be to kind of some of Duncan's slides, those pretty graphically showed where there could be some direct cost savings. But under the regulations, in connection with selecting criteria, it's pretty clear they have to be based on quality. So I think there's going to have to be a quality metric, and maybe even a quality gate, like the CJR regulations, above which gain sharing will occur. But I think, just to enter into collaboration agreements that are purely focused, for example, on reductions in length of stay or spend per beneficiary, obviously could backfire, because you saw Duncan's slide about the variability in the the quality, for example, of post-acute providers in terms of readmit. You may reduce your length of stay, but you may accelerate your readmissions and increase your episode costs. So I think long-term, what this all says to me, if you're a post-acute provider, is, your quality data is going to be central to this whole negotiation. And it's going to have an impact upon, I think, those post-acute providers that are in the top quartile or the top portion of the quartile are going to have obviously more leverage in connection with negotiating transactions, or said a different way, are going to be more attractive partners for hospitals than those in the bottom. But I see this. I see these agreements, apart from how the hospital is going to allocate risk between itself and post-acute and doctors. I see these being sort of hybrid documents that will have multiple levers on them involving both efficiency and quality.
Okay. Duncan, as a hospital is approach their participation in the CJR, do you recommend that they engage all their orthopedic surgeons, or are there certain physician groups that they really should focus on getting engaged in addition to the orthopedics?
Yeah, it's an important point, because there's wide variation in the number of surgeries that individual surgeons do. So capturing within this program the high volume ones are critical, but also as you drill down into the data, there's going to be some outliers that aren't positive, and so engaging them in this process in care redesign is critical, because those will often be the cases that are above the target price. And there's value in gathering a larger group into this program. So engaging a whole group, there's synergistic effects in that preoperative period of a whole office or group of surgeons appropriately working up the patient in that preoperative period. The final piece of that is that I do think that there are actually probably other physician groups that should be engaged. As I said before, that 85% of these cases, 80 to 90% of these cases are elective, but there's the remaining that are emergent, and these are the ones that just pop up in the hospital, often have comorbidities. This is a life event for the patient, and they need to be managed appropriately. I'd suggest engaging the hospitalist in that process, because those patients, those emergent patients, will oftentimes be on their service line, and they can, if you set up a co-management or a rules of engagement, the hospitals can manage the medicine, the medical side of the patient, the comorbidities, and the surgeon can do the operation. And working together, we found very nice synergistic effects there.
Yeah, and from your slides, it's also critically important to get patients ready for discharge and make sure that where you can discharge home. You can make a significant savings so long as the medical indications are appropriate for a discharge home. So preparing the patient for discharge can be very critical as well.
Absolutely.
Hospitals are required in their contracts to have quality criteria for selecting providers with whom to contract for gain sharing or downside payments. Are there some examples of the types of data that you can look at when you consider the quality of post-acute providers and the like? And I thought I'd take a shot at addressing that. There are the STAR programs, and CMS does have data. The 5-star quality system for SNFs is on the Nursing Home Compare website, and it talks about health inspections and staffing levels and resident level quality. And more recently, beyond SNFs, we've seen home care agencies now have a home health compare website, a quality of patient care star ratings that was started about a year ago, and there also are patient survey star ratings. Hospice has a comparable quality data that's reported by CMS, is reported to CMS and then made public, as do IRFs. So those would be one kind of a fairly simple method to say you have to have a star level of X in order to be a collaborator. in addition, it would make sense to consider gathering data from proposed contractors and tell them to come to you with their quality criteria that you build into their selection process. Looking at survey results from SNFs may be a factor that some hospitals may want to consider, for instance. I don't know if anybody else has anything to add to that. If not, we'll move on.
Actually, Fred, on that point, as maybe the post-acute people on the phone know, the impact law, which is going into effect for SNFs, IRFs, and LTACs by, I think, January 1, 2018, is going to require all kinds of quality data that's going to have to be reported and available to hospital discharge planners as part of the new hospital discharge COPs. So I think, with all these programs running around, I think the intersection of some of these laws, like the impact statute, the new hospital discharge conditions of participation, are actually going to feed directly into the CJR. They're not going to be there in time for CJR, to be implemented. But over time, I think you're going to find some of these programs. It's all about quality data, and you can see where the government is requiring it now as part of the discharge process, but it's also feeding into the selection process in these collaboration agreements.